It's a real pleasure to be here in a community, in a Sikh community. I was sharing with Dilraj Mamaji earlier that I used to go to the Gurudwara and the Mandir every week, to both of them, because that's the culture that was prevalent in the 1970s in Nairobi, where I grew up, and we didn't see a difference between whether you went to the Mandir or the Gurudwara. So it's really nice for me to be here. And thank you for that welcome. So I'm the co-director of the Collaborating Centre for Values-Based Practice, which is based in Oxford. I'm going to go through a few things today. I'm going to talk a little bit about assumptions that are made in healthcare, and then a brief introduction by way of an exercise. So you're going to have to do a bit of work on values, introduce that concept, which might be new to some of you. I want to touch on something called the Montgomery judgment, which is new law from April 2015. A bit about how we're trying to disseminate this in the hard end of medicine, in surgical care, which is my area of expertise, and then hopefully plenty of time for you to ask me questions and hopefully challenge me in some of those things that might become apparent. So assumptions, what do I mean by that? Well, that's from the, you'd expect a professor from Oxford to bring up the Oxford English Dictionary. It's the number 10 brand in the world, but it's a noun that, something that's accepted as true, but without proof. And that's the problem. And another word that's really important is surely, and now, ever since I started thinking about this, someone says surely. If you're any primary school teachers in here, they talk about something called persuasive writing. If you want to persuade somebody, you say, but surely. And if somebody says that to you, you should start having a radar going up, because what they're really doing is that they have this firm belief that what they're saying is absolutely correct, must be right, and you should not dare to challenge that. And every time you hear surely in a medical consultation or a conversation with somebody else, your radar should now be up, thinking, what are they saying here? They're saying, I must do something. And they might not be right about that. So how do we challenge assumptions? I just want to give you some examples. It's where we have blind spots. We all have them, and that's where they come up. So these are just some examples I found from Wikipedia yesterday on some examples. I'm just going to let you read those, and one of them I did use with Dilraj. You can probably guess which one. His mum and Mamaji will be pleased to know I said that to him. Right, we move on. So the assumptions are really a big cause of misunderstanding, because if we make an assumption, we're just assuming that you will just do as I am recommending or directing, but also it means that we haven't taken the time to understand the other person. And this is the worst assumption of all in healthcare. And if any of you play Russian roulette, I hope not, but there's usually only one bullet in there, and of course the other 5 doctors are going to think it's okay. So let's talk about values. To do this, actually the GMC has very good guidance. It's really a question of how well that's applied or followed in everyday practice, and to do it well actually is quite hard. That doesn't mean we shouldn't do it, it's just it is hard. So they talk about doctors and patients making decisions together. And sometimes you might have to just think back to the last consultation you had and say how much of a say you had in what the outcome was, and did you leave happy? Because if you didn't leave happy, there's probably not a shared decision-making model. And so that's a really good test, is when you leave to say, are you content, and are you going to do whatever you've agreed to do or think you've agreed to do? So the best example of that is that of all the prescriptions written in the NHS in England and Wales, 1/3 of them are never even cashed in. So if somebody walks out with a prescription, so you're agreeing to take this away, and you never go and even cash it in. And another third are cashed in but never used fully as directed. So that's telling us there's an intrinsic flaw in the healthcare system, that 2/3 of the time what we think was agreed at the end of the consultation never happened afterwards. So yes, laudable GMC aims. What is it really like in practice? And that's one of the tests to say how well are people managing to do what they think they've agreed at the end of a consultation. So I'm going to make you do an exercise, and I promise you I never say this in a consultation myself. The whole thing about I have good news for you and I have bad news for you. But today I have got some bad news for you. And the bad news is that you have to imagine that you've got the symptoms, early symptoms of a potentially fatal disease. The good news is that there are 2 very good evidence-based treatments available. And I'm going to add in better news that not only are they available, but NICE, which is the National Institute for Clinical Excellence, has approved them and they're fully funded. Okay, so you not only are they available, you can have them. So this disease you've got, there are 2 treatments. Treatment A is one of those guaranteed period of remission, and for a period of X in months and years, you'll be completely well as you are today. You won't be better than you are today. You'll have the same quality of life, and at the end of that period X, you will drop dead, and I'm going to make you drop dead painlessly. Okay. Or you can have treatment B, which is a 50-50 kill or cure, and you're going to have that tomorrow morning. It sounds a bit like surgery. Okay. And from the moment you have that treatment, you'll have an injection in the back of your hand, and then at the end of it, you'll either be cured back to normal for you as you are today, or you won't wake up. So it'll be painless. So what I want you to do now is to think, without conferring, how long a period X would you want for you to take that treatment A option, or rather than the treatment B tomorrow morning. So if you can just think for about 30 seconds, and you've then got to write down that number X in months or years, either on your mobile phone or a bit of paper if somebody needs a paper, but have that number in your head. So I'm going to leave you to think for 30 seconds or so to do that. You're going to put it in there? You're not allowed to change it. Okay. So you do have to make a commitment to that number. I see most of you not writing it down. You're probably just going to think of that number. Okay? No, not yet. Not yet. Has everyone thought of a number that they're committed to? Anyone not decided yet? Okay, you've all decided. If you've decided on a number, do you want to talk to the person next to you and find out what his or her number is and what your number, what you've chosen? Okay, if you do that now. Talk to the person next to you. What did you pick, sir?
I'm still getting it in.
Oh, you didn't put your hand up, so you hadn't got it in?
No, I didn't.
What did you decide, sir?
Well, it depends on what the doctor says.
That's it. You got to decide. You have to decide.
Yeah, I think I can discuss it with him.
No, you can't. You have to decide. Okay. Have you decided a number?
I'm just still thinking.
Oh, yeah.
I'll go for treatment A.
Okay. If it's an emergency while you're still thinking, you'll be dead. So you better decide fast. How about you, sir? You decided? Sorry? Yeah. 15. How about you?
I didn't decide a number. I said so there's no number. It's my dad's name. Whatever.
Which is what? Well, okay, that's an indecision. It's a decision of indecision. What did you decide?
I didn't know. I was late. Sorry.
Oh, right. You have to read. What did you decide? A year?
Well, I was thinking about 4 to 6 weeks.
4 to 6 weeks? How about you? 2 years? All right. What did you decide? 10. 1 year. Okay. Interesting. You need to talk to each other, right? How about you, sir? What did you decide?
The number?
Yeah.
I have to tell you.
You do.
5.
5? 10? No. He picked a year. You better talk to each other. Okay, going by the noise in the background means you're either having a good discussion or having too much fun. So I'm going to stop that. So the next bit is something that, because it's quite a big number in here, we're going to do it at speed. I hope those of you who are still being indecisive when I came round have now decided, because what I want to do is to go through every single person in the room, and you've got to tell me the number X, or if you couldn't decide, can't decide. Okay? So if we can just do that at high speed. We'll start with Dilraj.
10. Yeah.
10.
Yeah.
Next. 10. Next. 1. Next.
5.
5. Next.
100.
Okay.
Thank God.
One deluded person in the audience.
60 years.
60.
20.
20. 20. 20. Couldn't decide. 15. 10. 2 years. 5 years. 10 years. 1. 5. 10. 20. 20. Couldn't decide. 40. 10. 10. 10. 10. Couldn't decide. Can't decide. 1. Okay. 10 at the back. 20. Can't decide. Can't decide. Can't decide. There's a little group of indecision going on over there. And, okay. 20. Thank you for being decisive. 15. How about you guys? They were arguing. Are you married? Just say what she said. Okay.
He's a wise man.
Yeah. What did you say? 40. 40. Yeah, very good, sir. 37. 10. 20. 20. 15. Just keep it down for a second. Keep going. Couldn't decide? Oh, you decided now? Yes, sir. Sorry, go on.
No, I said until I die, whatever that number.
Okay, that's an indecision. Behind you, sir. 15. 15. 10. 10. 10. 15. 20. 6. 10. 10.
I said 1 month, but I mean
1 month. Okay. Go on. 10. 15. 14. 5. 10. 2.
I said 1 month.
1 month. A year. A year. You've already decided, haven't you?
Yes.
Yeah, okay. Now, look at that. Are people surprised by that? Same evidence. Some people couldn't decide. Now, we've done this now. This is 136 times, this same exercise, in groups from 20 to 687 in the Sheldonian Theatre in Oxford at an international conference. And we virtually always get a distribution that's a bit like this. Sometimes the peak is 20, sometimes it's 30. And sometimes people say, well, it depends on your age. And actually, it's not true, because we do this for our 21-year-old, 22-year-old medical students, all of them exactly the same age, and we have exactly the same distribution. I did it in a room with a group of educators in the Thames Valley. I was the youngest person in the room, and we had the same distribution. Now, just for 2 or 3 minutes, I'm going to pick on 2 or 3 people. I'm not going to pick on you individually. I'll give you a choice to say why they picked what they picked. So somebody who picked 20 who wants to speak. Yes, sir.
I chose 20 because looking at the 2 treatments, I thought I'm 60 years old. 20 takes me to 80. Even though there's no cure, but at least I know it'll stop in its track.
Yeah.
That was the reason why I went for 20 years.
Okay. So someone who picked 10. Anyone who picked 10 wants to speak? Yes, sir.
I picked 10 for the reason that remission period is sufficient. Possibly there may be some advances in technologies, which perhaps in future there may be a cure.
So there might be some advances and so on. Someone had picked a month.
Okay, maybe I didn't understand the question very well initially. I think that's an important one to think about. But also I believe that it's quality of life. Yeah, it's no use being ill and kind of you can hardly walk or whatever it is, and you just keep on suffering. It's no use being around here when you're still not well. Huh?
Sure. And a lot of people think like that. They think that there's a difference between prolonging life and prolonging death. And one of those is really bad. Okay, someone who picked 5 years. Anyone picked 5 years want to speak? Sir.
Because of my birthday.
Well, explain what do you mean by that?
It's my birthday, that's all. That's what
Okay.
I
Okay, so right.
No other reason.
All right, very good. Okay, so people can have. That's just an example from 40 21-year-olds who are all medical students, undergraduates in Oxford. And two of them, again, said they wouldn't even choose it, they'd go for treatment B. Some people can't decide. There's somebody who said, I can't possibly make this decision without talking to my wife. So we had somebody like that here today as well. You'll have a very happy marriage. So when it comes to your decision, you can have the same evidence, but if you have different values, if you have different things that are important to you, you just got a small flavor today of what was driving people's decisions, and what was driving was the things that are important to them. And if you do this in fact, you could recommend this at a family party. You could go around and ask everyone, and that could be the last time you have a family gathering. So I just want to tell you how this came home to someone. So actually, the couple, they were very interesting because the very first time we did this exercise in Oxford, and I was working with a guy called Bill Fulford. He's a philosopher and also a psychiatrist. And there were two young doctors in training who'd helped us organize it. And when we came to asking this, there was obviously a really intense discussion going on. I think it's called marital disharmony. And Bill said to me, what's going on with those two? I said, well, you should go and find out. So he went and spoke to them, and she had picked 30 years, and he had picked 18 months. And when it came to saying to them, why did you decide that? He said, well, I've got to finish writing up my PhD. And she said, well, that's why she got really cross with him, because what Bill didn't know was that they were an item. They'd been together for 7 years. They'd just got engaged 6 weeks earlier. And she said, I was thinking about what we're going to do in 30 years. We're going to get married. We're going to have children. We're going to settle down, etc. And he was just thinking about his bloody PhD. And so she said for her, light bulb came on that this is someone I've known for 7 years and I can't work out what he would want. How can I second guess what my patients want in a 5-minute consultation or a 10-minute consultation? So for her, that was a light bulb event. And so actually sometimes having that discussion is quite good in a group like this because it allows me to tell you that story. So evidence-based practice, which is the drive and has been for 25 years, of healthcare, certainly in the UK and large parts of the English-speaking world, is this process where we know there are complex and conflicting evidence sometimes. We haven't got the right answer in medicine for everything. That's a big surprise to lots of members of the public. And evidence-based medicine can help you say, well, these are the real choices you could make. The treatment A versus treatment B. There is no other option. Well, the only other option was death. Okay. But values-based practice is where there are complex and conflicting values. That's what we all bring to the table, is the stuff that's important to you personally, individually. And we've just shown that all of you were going to make very different choices if only someone had bothered to talk to you for a bit longer to find out what was important to you. So, and it's not that we're anti-science, far from it. I'm a professor in one of the most scientific medical universities in the world. In fact, just hot off the press, Times Educational Supplement this week, we're #1 in the world for 3 years running, which is great. But we're not the first people to think of this is a guy called David Sackett, who was the original father of evidence-based medicine 30 years ago. He's a Canadian who came to practice in Oxford, and he set this up. But he said real evidence-based medicine was the combination, the integration, best science evidence, really good clinical experience and expertise, but taking into account the individual's values. And what's happened with evidence-based medicine the last 25 years is people have forgotten the third bit. They've forgotten that. So I'm pleased to say that the National Institute of Clinical Excellence, their chief executive is on our advisory board. They've now put this into every guidance that the NICE comes out with. It starts saying how to use this guidance. You must take alongside the individual's needs, preferences, and values. But now there's a new law that helps us. So does anybody here know about the Montgomery judgment, apart from Dilraj? Okay, this is really interesting. So I'll tell you about it. I'll spend a couple of minutes on this. So Mrs. Nadine Montgomery is a woman who has diabetes, and she was pregnant. And we know that if you have diabetes and you're a woman who's pregnant, that's called a high-risk pregnancy. And she's under the care of actually a very good obstetrician. This is a Scottish case, Dr. McLaren. And when she had her discussion with her about her birth plan, she started to talk about having a caesarean section, and Dr. McLaren said, stop. I mean, literally with her hand out, stop right there. And she said, no, we're not discussing that. It's not in your interest. We're not even having that on the table. That's an option not to be discussed. And what actually happened is that we know the facts are that if you if you have diabetes, you have a big baby, the baby can get stuck in the birth canal and you can have a prolonged second stage of labour. The baby can have brain damage from hypoxia, but also the baby might not be able to physically fit through the birth canal, and the shoulder can end up being dislocated. That's called shoulder dystocia. And very sadly, that's exactly what happened to Mrs. Montgomery, and her baby was born with some brain damage and paralysis of the right dominant limb. And that's a very devastating thing to happen. And she then sued Dr. McLaren, and at that point the law was something called the Bolam, that if a reasonable group of your colleagues thought that was a reasonable thing to do. So what Dr. McLaren said was, look, if I say to any mother that there's a danger to the baby, although very low, the mothers will always protect the baby, and they'll say, no, I'll have a caesarean section. And on balance, in her expert opinion, the evidence was that the vast majority of women, not every woman, but the vast majority of women, would benefit from having a normal delivery because it was probably going to be okay. And what Mrs. Montgomery was saying is that had she known that risk, for her personally, she would have been one of these people, the outliers, people who make decisions about 100 years or a month, who are different to the rest of us. That doesn't make them abnormal, it just makes them different. And she would have made a different choice. And so she went to the Supreme Court, and the Supreme Court turned it round. And interestingly, the Supreme Court at the time, they said that, yes, of course you should have the prudent clinician, the sensible doctor who would make a good decision that the vast majority of doctors would make. But actually that's not taking into account the individual's views and options and choices they would make. And so this shifts the law in favour of what we'd call the prudent patient, picking a choice that's right for you, which might be different. Okay, so this is not about bombarding people with information. It's not about giving you tons of information, which a lot of doctors think. In fact, the Royal Colleges have thought that. But it's actually just having a conversation with people. So it's about a dialogue, and that's what we want, where we can take into account what's important to you. So that's now law from 2015, and people are struggling with that. I'm going to skip over what we've done in surgery to basically say there are pitfalls in surgery. That you can believe you're completely right about everything, and then you can talk about building a wall. And surgery is about people knowing their limitations, and not about turning up on the day and thinking that you're feeling lucky and yes, I'll get you through this operation, where the evidence is against you. So we've done lots of seminars and we're trying to persuade people. The key is that our seminars always have patients in them. The patient's voice should be heard when we're making decisions and when we're training doctors and surgeons of the future. So I'm going to give you one quick story to bring all this together. This is a real story. A lady called Mrs. Jones, who was in Oxford. She had a very painful knee. She's in her early 70s and she had bad arthritis, and she went to see a GP, got fobbed off, went to see a GP, got fobbed off. Third time she got referred to see the orthopedic surgeon. He did a full assessment and he said, you've got bad knee arthritis. We're going to talk about one option is a knee replacement. He gave her all the risks and benefits, and she agreed, and she was going to have a knee replacement. She was on her way out of the door, hand on the door, and said, I'm so glad, doctor. I thought I'd get fobbed off. That's what my GP said. And that I'm going to have a knee. Now I can garden. And he said, really? Come back in and tell me about gardening. And it turned out that she said she's retired, she's widowed unfortunately, and the love of her life, 7 days a week, rain, hail, sunshine, she'd be in the garden doing gardening. That was the thing that kept her happy and lively and so on. She said, well, now we have a problem. Because the one thing I can't guarantee after a knee replacement is that you can bend your knee fully and you might not be able to garden. So she said, well, in that case, I don't want to have this treatment. And so she didn't have it. She had physiotherapy, painkillers. 2 years later, she's still happy gardening, no knee replacement. And so with the conservative management, this is true values-based, listening to what was important to the patient. Yes, we're taking into account the best evidence on what the options for her were, but it did mean that for her, it was a better outcome. She could carry on gardening, and actually it turns out it was cheaper for the healthcare system because we saved £10,000 that somebody else could have their knee replacement from rather than wait in misery and agony for longer. So I think what I'd finish by saying is that how values-based practice has changed what I do in my clinic, every decision I have to make, is that sometimes it's very obvious. You know, there's a risk of having a stroke or dying. You can have surgery to fix it. Risks are really low. Benefits are high. I can say, I'm recommending this treatment to you. You can still say no. At the other end, you might want a particular treatment or think you want a particular treatment where the risks are really high, the benefits are low. And I can say, I'm not going to provide you with this treatment. I can see you're unhappy with that, sir. Would you like a second opinion from one of my colleagues? And I openly offer that to patients. But in the middle group, there are lots of things where you have 3 or 4 different options. And people say, well, what would you do, doctor? And what I used to do was say, well, that's fine. You know, for example, varicose veins, I'd say you should have surgery, you should have injections, you should have stockings, you should have laser treatment. And that was based on what I thought would work for you, based on what was important to me. I don't do that anymore. I say, well, really interesting you should say that to me. Why don't you tell me what sorts of things are important to you? And then together we can pick the option that will suit you the best. Okay, so just to summarize then, is that beware of the word surely in a conversation, particularly with a healthcare professional, but actually it's quite helpful in general life as well, particularly at work. You know, people say, surely we must do X, Y, Z. Somebody says that in a committee meeting, be worried. This is going to change your committee meetings. I'm sorry for that trouble I'm going to cause you already. To assume is to do that. And we don't know what matters to someone unless we take the time and the trouble to ask them to say, well, you've got this problem, what sorts of things are important to you? What's going on that might work out? And what values-based practice does is to really bring that. So this is a way of when you have your consultations and you're making decisions to just think about, stop, and sometimes even before you go. So we're now training patients that you need to do your homework before you go to your appointment to work out what's important to you. Look stuff up. Dr. Google can be helpful in that respect and say, well, these are the things that other patients have found helpful. So we're just starting a project nationally where there's lots of information on NHS Healthline and Health Talk, but not the sorts of things that other patients have found helpful. And we're just starting that project nationally with 10 conditions to start with, and then we're going to hopefully get NHS England to fund it for the 400 common conditions in the UK. Thank you very much.
Your phrase surely reminded me of the airplane. If you see airplane, anybody?
Yes.
Or film? No, surely you don't mean that. Yes, I do, and stop calling me Shirley. Thank you.
Thank you. This is a great talk, thank you. And I understand how this benefits individual patients. what if the patient's values are in contradiction to general population health, like herd immunity or vaccination or things like that?
Well, that's a really good question, and of course herd immunity relies on around 95% of the population agreeing to do that, and the higher the percentages the better. So one of the things that are worth thinking about for, maybe we can just,
Should we just flip it?
yeah, I'll just turn it around. Flip it around?
No, actually, no.
Oh no, okay. Yeah. So the thing to understand is that when you have a population with anything, whether it's height, shoe size, etc., you have this normal distribution, and by definition we're saying that people here are outliers. But in herd immunity you have to say, well, what's best for the community? But it doesn't matter if some people make that different choice. It's okay. There's enough leeway in biological systems that would be okay. As a community we can probably accommodate that. It's when people are misinformed and everyone makes a choice that is bad, not just for them individually, but bad for the whole community. So I think if you articulate that to people, there's still room in most systems and communities for some people to just have a very different viewpoint. That doesn't make them unreasonable, it just makes them different.
You know, when you go to a professional, a doctor or who's a specialist in a certain kind of discipline, don't you think they are the best people to kind of guide people as to what should be done, because they see these cases day in, day out? And if you have an issue, you know what's important to you, but the consequences and the long-term issues which are going to come out of whatever is happening to you, you cannot actually visualize it. But you've got case histories to prove it, that this is probably a better way to go. Because when I go to a doctor, I expect the doctor to guide me through what I should do. Obviously they should rate what the risks are and what could potentially happen. But we rely on professionals.
You're quite right, and what the professional is bringing to the conversation is the evidence base, the scientific evidence, their expertise on what sorts of things will work for particular patients. But what they don't know is what's going on in your head. And just like that young doctor who had no idea that her fiancé would have made a very different decision, unless you have that dialogue. And the current danger is that we don't have that dialogue. And when patients say to you, what would you do, doctor? Because you say, well, you're the expert, just as you've articulated. You'd say, well, I would do that. But that's based on what's important to me. I'll give you an example. Even something simple like varicose veins, I might say I have a personal bias because I know I get very good results with surgery, and I know that lots of patients who have the injection treatment are back in 3 years, 4 years, 5 years. But actually it's expedient for the NHS to provide them with outpatient foam treatment. So there's a huge push to do that. But for some patients, they would say to me, what would you do? I'd say, well, I would probably go and have surgery because I know I can get them a very good result. But they might have a needle phobia, they may not want to have time in hospital, they may have 3 young children they need to look after, and for them it might be better to have the other treatment. So it's about part of that expertise is also knowing that different things will suit different people, and to just have that dialogue to say, these are the consequences of these decisions. Now do you want to make a better choice based on what's important to you? So I think it's going that next step. The easy way to do it is to have a paternalistic model where you say, I know best for you. And in a way, when I'm on the other side of the table, I do want to go to an expert who knows what to do. So sometimes there can be a difficult conversation where they're saying to you, well, I know what's best for most people, but I may not know what's best for you. Let's work it out together. Just speak up if you can.
Going on from what you just said, you go with your best value practice and you come through and you decide, and isn't the consultant's decision also reflects the finance that's there from help? because that's the key thing, isn't it? They will fob you off with something that, as you said, pushed in a certain direction because of funding.
So mostly, NICE are there to help us make those decisions as a nation, so that the funding side is predetermined. So I can only offer someone treatment based on what's available and out of that. And in fact, as it turns out, sometimes the things that aren't funded, not funded for a good reason, that they don't have a really good evidence or scientific base, and they're being driven by pharma or by other device industries. One example from vascular surgery, my expertise is repair for aneurysms, endovascular aneurysm. Everyone thinks it's a great idea to have keyhole surgery, and actually it turns out that if you're going to live more than 5 years, it's a terrible idea, because it just doesn't work beyond 5 years, and it also turns out that it's more expensive. But it wasn't the fact that it was more expensive that was the problem. The problem was that actually it doesn't work at 5, 6, 7, 8 years. You end up having to have more and more surgery, and it doesn't change the underlying problem. So I think sometimes you're right, there might be a financial... We're lucky, I think, in the UK, in that in the NHS, most of those funding decisions are either supported or not supported by NICE. So it's not the individual person's funding that will affect you.
But mostly decisions are made about funding by GPs and GP surgeries. They will turn around and say, well, actually, this is cosmetic. And I'm talking from personal experience. So if a GP makes that decision that this is cosmetic, they're not really looked at value-based practice.
Well, actually it is, and I'll explain why. Because the decision isn't made by that individual GP. They should be following the guidance from the clinical commissioning group, who are the people who commission. And it is true that in the UK, in the NHS, we don't have an unlimited amount of money for healthcare provision. Changing the way that I might look, I might like to have an abdominoplasty and look a bit thinner. That'd be very nice for me, but actually, one, it's not sustainable, and two, I'd find it very hard to justify using money for that when it could do something good for somebody else. So we do have to have those conversations at society level, and most of those funding decisions are, fortunate in this country, are made by NICE rather than in many other parts of the world, made on whether you can afford it or not. Probably last question, I think.
Really important topic this. So, and it's really about empowering patients and getting that shared equity in decisions, isn't it? So, given the age of misinformation that we live in now, what would your advice be to this group to those who actually do want to go away and find out more?
That's an excellent question, and there is almost too much information out of there, and the difficult in the digital age is sifting through to see what's attributable and correct and not driven. And behind many of those information lines for patients online are hidden behind that are pharma driven, device driven, even driven by particular practitioners who want to provide that service on a item per service pay. And so I think the verifiable are things like the NHS line. Virtually everything now has NICE guidance, and I think the NICE guidance should be your go-to place, and the NHS Health line on information and factual knowledge. And then I think we do need more of this empowering of people so that you can go with both some information but also a view about what would be good for you personally.